Our team then turned that into web elements, which is easy because it's a web application. And then there's some email discussion on the group. So the group will get, so this is the glaucoma group, they get an email with a link. So they're all busy people. All they have to do is click on the link, and they go straight to this in their browser. And this is recording details about an optic nerve, which is damaged in glaucoma. That's why you lose peripheral vision. So this is doing a notch in the optic nerve where you've lost that amount of nerve fibre and you've got a corresponding field defect. The group then play around with that and then feedback by email saying that's absolute rubbish, or no, that's perfect, or usually somewhere in between. And we keep going through that iteration until everyone in the group is happy. And then all we can do is drop that into the product. Lots of discussion, and particularly on glaucoma, this became very heated. So one of the real challenges in this is getting clinical agreement. But this process does end up with clinical agreement, perhaps with a little bit of beating people around the head. And then there's piloting, and there's another phase of feedback when people actually start using it. We've probably got about 70 ophthalmologists nationwide, with some abroad as well contributing to this. And that's a really exciting aspect of the project. Now, before getting on to why we did it as open source, I thought I'd better just tell you what I mean by open source, because it's still a relatively new concept within the NHS. So what I mean by it, the source code is published, and nowadays that means it's downloadable. And you can use it. You can download it and install it, should you so wish, on your laptop. It'll take you a few hours, but you can do it. You can modify it, and there's no license fee for its use. Now, software, I'm old enough to remember doing punch cards on computers. The software used to be largely open source. The open source model was really introduced to allow the license fee model to work financially. That was why it was introduced. There are all sorts of arguments about which is better, which is really for the pub rather than here. But it is a bit strange if you think about it. And if you think, well, in other fields of life, if cars were closed source, you wouldn't be able to do this sort of modification. You may say that's not an improvement, but you wouldn't be able to do it. If houses were closed source, you'd be buying a house without a survey. The owner would say, no, it's fine. I'm not going to tell you how it's built, but you just buy it. And bring it a bit closer to home, if pharmacology was closed source, you'd be popping pills without having any idea what's inside them. But those aren't the main reasons. Why did we go open source? Well, some negative and some positive reasons. The main negative reason is this. This is our third attempt to get this right. Pilot in '97, that worked pretty well. We handed the pilot over to a commercial entity about here, and then that was pretty good. These blue bars are the use in the clinic, which is the real measure of success, I think. And you can see we got up to figures which were about 20% of our application turnover in 2003. And I thought, great, I can retire even earlier. And then that happened. It tailed off. So something went wrong about that time. And the two things, firstly, the company that took it over underestimated the importance of the sticking clicks. We had 2 clicks in the pilot to get a recoded diagnosis of version 3. They introduced 4 clicks, and guess what happened to the diagnostic ascertainment? Massively important lesson. And the other thing was this. So there, the financial model was to sell the system to other ophthalmic departments. They went around, the ophthalmologist said, yeah, okay, we'd like this. But the IT department said, why should we pay you any money when we're going to get a care record service which will do all this for nothing? Yeah. So their business model collapsed. They sold it to somebody else who charged us $250,000 a year for using something that we designed. And we couldn't develop it any further, and it was a disaster. And as we know, the national programme, I think most people accept that it's failed, although you might say, well, where did the 2% of benefits go? Well, they went on this mug, which is beautifully constructed and still doesn't leak. That's a negative reason. We didn't want to be in that situation again. Positive reasons, it's a really good fit for clinicians. Clinicians absolutely get this because this is the way they work. So if I had an idea for a new retinal treatment, I would do this. I'd tell people about it, go to a meeting and say, look, I've got this new operation. People would listen to it, go away and try it, come back to the following year and say, I've taken Aylward's operation and I've improved it a bit, and this is a new one. Precisely the sort of do want to share collaborative model. And the other thing, this is a really important point, is clinical engagement. So let's say we were doing this as a commercial entity. There are many examples of this in the NHS. So my expertise is limited to a very small part of ophthalmology. I ring up the leading glaucoma person and say, can you help with this? And what he's thinking is this. And if I put in all this time, which is an awful lot of time and effort, will Moorfields earn money? Specifically, they're thinking this. And this is really important. There's so many examples, even within ophthalmology, let alone outside, where people have contributed ideas to code, and then their trust hasn't been able to afford to buy it, so they can't even use it. With open source, all those concerns disappear, and that's really why we've managed to get so much clinical engagement. Speed and flexibility, the idea that we have different contributors making sure the whole thing appears quicker. So this is the Amish building a barn in a day, because they will do one little bit. Lower cost. There's no license fee, but that doesn't mean there are no costs, obviously. And I think looking at the total cost of ownership is certainly an interesting exercise, comparing that with commercial software. But if you then roll this out across the NHS, that TCO goes right down. So I think the cost argument is very compelling. There are downsides though. We found that the NHS particularly has got a cultural barrier to open source, or has had. These are all the trusts that are really interested in having open eyes. These are the trusts that have been able to download it and install it and run it themselves. So the others, the IT department simply can't, won't, aren't interested. And I mentioned this to those of you here last night. This was John's article only 3 years ago, where the idea of having open source in the NHS was, everybody realised this was an April Fool. But now, things have changed a lot. And that's very much due to the influence of NHS England, who really picked this up and are promoting it, and EHI in promoting the ideas and supporting the campaign. And that's really working. And the fact that we've got a conference full today talking about open source is evidence of that. As you know, open source is being promoted in Tech Fund 1, this is Tech Fund 1 and Tech Fund 2. So I think the culture is definitely improved. Control, when I mentioned the 3 sites, almost within a week we had 3 forks. So actually controlling an open source bit of software is really, really difficult. Well, it was a challenge for us. And the solution to that is that we formed the Open Eyes Foundation, which acts a little bit like the Apache Software Foundation. And the main aim of this is to prevent forking, to coordinate development, to ensure that there's no duplication of effort. And this exactly corresponds to the custodian role that Peter Coase has been promoting, i.e. a safe place to keep the software where it's secure, it's quality assured, and there's no forking. And sustainability is the other issue. How Moorfields is putting a lot of money, as you've heard, into this. And we've got contributions from NHS England, grant applications, Orbis abroad, and various other sources. But what happens once the software is largely complete? And is it sustainable? Does it just peter out like so many open source projects have done? And this is where we need commercial activity. And just because there isn't a license fee charged, doesn't mean there aren't commercial opportunities. And Red Hat is a brilliant example of this. They are a billion-dollar company now in the US, and their business model is essentially selling free software, or at least installing, maintaining, and supporting it. And we are setting up, or have set up, a Red Hat for Open Eyes, which will address the needs of all those trusts that can't do it themselves, and provide commercial income, which will enable the project to be sustainable in the long term. So I think in conclusion, it's a novel approach to health and practice in the sense that it's very clinically led, in-house, and open source. But I really believe the open source approach has got massive advantages, and it's time to have done. Thanks very much for your attention. We've got 5 minutes. for some questions now if people would like to. John.
Those three downsides or challenges, I can't remember the title of the slide, like culture, control, and sustainability. I would argue, and you'd expect me to because I'm a big fan of open source, that those are actually challenges that are irrelevant to the licensing model of the software. Whether had you bought proprietary software, you would still have had to address issues around how do we control it. You're just handing the control over to the vendor, saying, oh, well, they'll control forking or versions or whatever, to me, isn't a benefit of proprietary software. The fact that you decide, are we going to fork this, or are we going to embed the new changes into the version, is one of these sort of advantages of open source. And similarly, with sustainability, I've worked for proprietary software vendors who've decided to turn their back on the market. They said, no, I'm not going to do that anymore. And there's no sustainability there. Whereas with an open source solution, you actually, if Moorfields, for example, said, actually, we're not going to play with open eyes anymore, at least the code's out there, so that those trusts that are already using it have got the opportunity to continue to do so, even if you chose to go a different route. So I think I'm trying to do
those are very good points, and I think you're right that these are perceptions rather than realities. And there's one very good example, was it last year, with a very major GP vendor?
Year before.
Suddenly stopped.
Yeah, iSoft.
Yeah, so all the happy customers who invested all their time, effort and money in a proprietary commercial product were left in the lurch in exactly the same way as all the
I think the open source concept makes people ask the questions they should be asking of their products generally. It's just there's some built-in assumptions about proprietary software, which open source tends to actually bring to the fore. But there's still questions that need to be addressed in the proprietary space.
Yeah, I agree.
Hi, and I apologise for missing the start of your talk. Are you able to share with us the implementation costs at the two sites other than Moorfields Hospital and Cardiff and Native?
I don't have them exactly, but I know that Cardiff, for example, the main cost was one developer. So he was a contractor working £350 a day for about 6 months. And then there were hardware costs for a server that developer is maintaining. So they were pretty low. Maidstone, their business case was for £120,000. So what I don't know is whether they've had additional costs. Here, our implementation costs are being low, but in fact too low, because we haven't invested enough in implementation. So the bulk of the money has gone into development. And that's why that's part of the reason why we've had a little bit of problem with implementation. I mean, if you look at the way Epic implements, 10 hours classroom training, clinics cut to 50% for 2 weeks, etc. We didn't do any of that. We just said it's available. It's on the computer. The clinics were 120% overbooked, etc. So our implementation could have been better.
Just following up from the first guys, back to the control element, how much effort has that involved on Moorfields' part? Just thinking about John's point that you're not a software house, the primary responsibility, how that's...
At the moment, it's a fairly low level effort because we've only got those two other sites who are developing. So it's quite easy to coordinate. So when they say we'd like to do graph pressure over time, we can say, well, actually, we've already done visual acuity over time in this way for medical retina. Let's just convert that rather than starting from scratch. So that's probably quite a low level of activity at the moment. What we want to see is more development science, because although we've succeeded in getting lots of clinical engagement, which is brilliant, the software development could be more like other open source projects, and that would really spread the cost and increase the number of people to transition. I think we're struggling how to do that, but I'd really like to get to the same position as Apache arrange. I think they've got 2,500 developers all over the world working on hundreds of products, so that's a real example. James?
A couple of comments. plus developers working in the NHS around and about, but they need some coordination to help this work a bit better. Secondly, the cost of implementation for a lot of our stuff is integration rather than the actual software itself. You've not got many feeds in here. I presume you would produce documents for an EPR. You don't have a lot of blood feeds or anything like that going in, so that makes things a lot cheaper. And then finally, the sort of definition of open source, because I'd quite like you to hold one of our open source evangelists to account this afternoon. So for you, it's making the code available. What about the stack, as you guys seem to like to call it these days, the hardware that it runs on? How do you feel about that? Does it matter?
Yeah, I don't think it matters. I mean, our open source software can run on a commercial stack. So at the moment, for various reasons, I mean, we wanted to be an exemplar of open source. So we do run the whole thing on open source stack. So it's written in open source language, PHP, JavaScript. The database is MySQL, which is open source. The server is Apache, and the operating system is Ubuntu. So it's all open source, but that's not. We could have replaced all the stack with commercial equivalents and not affect the project in any way. That was really more a statement. Let's show that it can be done. But if a trust wanted to run this on a commercial stack, it wouldn't make any difference. I think we better move on now to the tour. Now, with a bit of luck, Josephine, if you were able to open the door, I think you might find some tour guides out there. So, this is going to be a bit tight for time. Firstly, if you look at the there is a number on it. And that number corresponds to the groups. They're going to be 4 stations around the hospital. And each group is going to go to each of the 4. And it's designed to give you a real flavour for the whole project. So it's going to be group 1 are going to stay in here for the first 15 minutes. In fact, it's 15 minutes, really 10 minutes plus 5 for the handover. So if you're group 1, you stay here. And Tim is going to talk about the organising of the clinic, particularly in relation to some medical records issues and communication with clinicians. Group 2 are going to go with Gwyneth. So Gwyneth is going to take you to the developers office, which I gather from various texts I've had this morning, the developers have spent the morning, instead of developing, which they meant to do, they cleaned up the office. It was not at my request, and indeed the first time it's been cleaned. So I'm sure if you say, oh, this office is clean, they'd be very Group 3, Ratner is going to take Group 3 down to the operating theatre. You won't need to change, because we're going to do this in the interface area. And 2 of the surgeons are going to demonstrate, talk about organising theatre. And then Group 4 is going to come with me, and we're going to go down to the server room and talk about the importance of infrastructure and see some flashing lights and computers and that, get things working. And then you follow on. So I've got these guys for the tour guides. So you got it. Yeah, this is fine. So let me tell you again. Is anybody not clear what group they're in? That's good. So Group 1's going to stay in here. Group 2 with Gwyneth. Group 3 with Ratner. Group 4 with me. It's going to be a strict 10 minutes in each location, then 5 minutes to move. And then we should be back in here at 11. That works.
It could be dangerous.
Yes, we've certainly covered this. So Group 4 is coming with me.
When do we get
Well, I
see you this afternoon?
I'm going to start here and then.
Sorry, 4:30.
1:30.
okay.
Is that all right? Do you want me to? Sorry.
All right,
What's happening?
Good morning, Matt. Sarah, don't go. This is going to be the best station.
No, we come back. We just
Several rude words in your name.
5 minutes. I better get my.
Sorry.
Good morning, everybody. I'm Tim Elliott, and I'm responsible for development and implementation of Open Lines, management lines at Moorfields. So some of the action of collating the differing opinions of 110 ophthalmologists has fallen into the system that we've got. And this task is almost impossible because I'm talking to non-ophthalmologists, but it's in contrast to the high-level discussions and presentations that we're going to have during the day. We thought we'd go completely to the bottom and show you the system, because to leave without having seen it working would be a shame. So I'm going to do a little presentation with slides, and then I'm going to show you one of the live instances that we've got to show you how it works. And we're going to focus on this. So medical retina is a subspecialty of ophthalmology, and they stick needles into people's eyes and inject very expensive medicines into their eyes to stop them going blind. And that treatment is paid for by CCGs, who quite understandably impose a very intensive reporting structure on each patient and the medical data that they receive in order to pay the bill. And so we're dealing with treatments here that are intimately involved with NICE guidelines and following algorithms to guide the junior doctors and senior doctors indeed to place patients into categories of either NICE compliance or non-NICE compliance in order to give them the treatment that the clinician thinks is warranted. So putting expensive drugs into eyeballs to prevent blindness is what we're going to discuss, and that's done by medical retina. And that simple act is then covered by Open Eyes in those events there. So in order to do that to a patient, data needs to be recorded in the examination event. There then needs to be an application or notification form sent to the CCG by the contracts department of the organisation, Moorfields in this case, in order for the treatment to be approved and paid for. There's a consent event, so that the patient says, I don't mind you doing that to me. And then capturing the event itself during the injection, rather like writing up social notes or op notes, is the last event. So we've got a lot of functionality to present to people who are in very busy clinics having to do it very quickly. So the challenge is to get them to enter the data once and to pull that data through, where possible, to all of those events so that they're not having to put the same stuff in twice. Open Eyes is all about removing the barriers that would prevent someone from using the system and giving them every possible incentive to use it, because we're fully aware that you can have the best system in the world, but if it sits on the shelf and people don't use it, no matter who you are, it is dead. So compliance and use rules everything that I do in this project. So we've got screens that look like this. As Bill said, that pencil and paper is just the most difficult thing to compete with an electronics system, because it's so easy and so good. And ophthalmologists are a breed of doctor that particularly like pencil and paper. They like drawing. So we've got a drawing tool. This is the retina, and the clinician can select a pathology here. They can place it onto the retina. They can size it. They can position it. And as he showed you, clicking report there turns the diagram of the drawing into diagnostic narrative and codes in the background to Snowman CT. Fantastically slick. We can also take the drawing, and if a function called diabetic retinopathy grading is enabled, the grading system will interpret the drawing and grade to the national standards in the background. It can be overridden, but that works like that. So that's an important feature. We've got on-screen help, so again with diabetic retinopathy grading, if the user clicks the information buttons, they get grading criteria. We've got visual help, so again, click the camera icon, you get the screen looking like that.